Hi everybody, welcome to our module on cystic kidney disease. So there are dozens and dozens of diseases that cause cysts in the kidneys, but there are just a couple that you should know about as a medical student, and we'll talk about these in this module. So the first one is called the multicystic dysplastic kidney, and then there are two forms of polycystic kidney disease. There's an autosomal recessive form and an autosomal dominant form, and then finally there is medullary cystic kidney disease. We'll go over all of these now. So first we'll talk about multicystic dysplastic kidney, and this is something that happens to the developing fetus when there's an abnormal interaction between the ureteric bud and the mesenchyme. So let's talk about what I mean by that. In the developing fetus, there's a structure called the metanephric duct, and it gives off a little structure called the ureteric bud. And out here there's tissue called mesenchyme, and the ureteric bud interacts with the mesenchyme and it's going to form the kidney. And this interaction is essential for normal formation of the kidney. Signals are sent from the ureteric bud to the mesenchyme and then back from the mesenchyme to the ureteric bud. If this doesn't happen normally, lots of different conditions can develop where the kidneys are abnormal, and one of those conditions is multicystic dysplastic kidney. So this abnormal ureteric bud mesenchyme interaction occurs and the kidney essentially gets replaced by cysts. So the key point here is that no or little functioning renal tissue will be present in the developing fetus. In addition, there'll be an absent ureter, and this is usually detected in utero by an ultrasound on the pregnant mother. Now if this happens on one side, the other kidney will be okay and it can hypertrophy and do all the work of filtering the blood. However, if both kidneys develop multicystic dysplastic kidney, then you'll get what's called Potter syndrome, and this is where the baby doesn't produce urine, so there's oligohydramnios. The fetal lungs don't mature, and this will ultimately cause fetal demise. The baby will not survive because of the lungs. And then because there isn't amniotic fluid surrounding the fetus, there will be compression of the face and limbs when the fetus develops. And as I said before, this is not compatible with life, and these babies will either be stillborn or die shortly after birth. One very important thing to know about multicystic dysplastic kidneys is that they are a spontaneous occurrence. This is not an inherited kidney mutation, and this makes it different from all the other cystic disorders we're going to talk about today. So women who have a baby where one or both kidneys are multicystic can have other pregnancies where everything will be okay. Some of the other disorders we'll talk about today, the mother can pass the disorder on to subsequent pregnancies. So next we'll talk about the polycystic kidney diseases, which are very high yield for your boards, and there's two forms: the autosomal recessive form, which occurs in infants, and the autosomal dominant form, which presents in young adults. So autosomal recessive polycystic kidney disease is abbreviated ARPKD, and its old name was juvenile PKD, which helps you remember that it occurs in infants. If both kidneys are affected, you can get Potter syndrome, like I described before, and the biggest problem among children who have this condition is that they get renal failure and high blood pressure. And it has some other associations that you should know. This includes liver involvement, so there can be fibrosis and even cysts in the liver in babies who have ARPKD, and they also can then develop portal hypertension and ascites from the liver involvement. Now contrast that, what I just described, with autosomal dominant polycystic kidney disease, which is the much more common type of polycystic kidney disease. This occurs in adults. So what happens is that people who have this condition are born with tiny cysts, but they're too small to see on ultrasound, so the kidneys appear normal at birth, and in utero, when you image the kidneys with ultrasound, you don't see anything abnormal. But over many years, these cysts begin to develop, and this is caused by inherited mutations of two genes named after the disease, APKD1 or APKD2, and it's autosomal dominant, so this means that any affected person has a 1 in 2 or 50% chance of passing it on to subsequent children. So here are some pictures of polycystic kidneys, and they like to show you pictures of this disorder on board exams. Over here on the left, these two kidneys are enlarged with multiple cysts. Over here on the right, you can see these kidneys in here are very large and they're lumpy bumpy from all the cysts that are present. It's happening on both sides of the body. There are a couple of very important and high yield associations with ADPKD that you should know about. And the first one is Berry aneurysms. These are aneurysms in the brain in the circle of Willis, and if they rupture, they will cause a subarachnoid hemorrhage. And in fact, many patients with autosomal dominant polycystic kidney disease die from subarachnoid hemorrhage. Patients with this condition also get liver cysts, and they can also develop mitral valve prolapse. So the classic presentation that you should know for your boards will be a young adult who has high blood pressure. Why do they have high blood pressure? That's because the renin-angiotensin-aldosterone system is ramped up from the polycystic kidney disease. They'll have hematuria from kidney damage from the cysts. They'll have renal failure because the cysts are destroying the kidneys. And then they will often have a family history of sudden death. And this is because it's an autosomal dominant condition and someone else in their family had it and they died from an aneurysm. So if you see all these things together, you should be thinking of ADPKD. The last cystic kidney disease I'll mention is called medullary cystic kidney disease. So this is also autosomal dominant, and in this condition cysts can form in the collecting ducts of the medulla. Now actually this name is a misnomer because most patients do not have cysts that you can visualize. It's a small subset of patients who have it, but nevertheless the condition is named after the medullary cysts. What's really going on here is that patients get fibrosis in their kidneys, so they will have very small shrunken kidneys, and this is different from the other polycystic kidney diseases where the kidneys are enlarged. One clinical problem many of these patients get is early onset gout from being unable to filter properly uric acid, and then they can also develop renal failure. So in this slide I've summarized the 4 forms of cystic kidney disease that we discussed. The first one is multicystic dysplastic kidney, and this is essentially going to be a baby in the womb whose kidney fails to develop because of cysts. It's often unilateral, it's detected in utero, there'll be cysts but no renal tissue, and remember there are often no ureters, and this is not hereditary, so the mom is not going to pass it on to other children. Next condition is autosomal recessive polycystic kidney disease. These will be infants or children with bilateral large kidneys. They often have renal failure, hypertension, and remember there's liver involvement, so cysts and ascites can occur from liver problems. Autosomal dominant polycystic kidney disease is bilateral large kidneys with cysts that occur in adults. They develop hematuria and renal failure, and then the key association are those berry aneurysms in the brain that cause subarachnoid hemorrhage. And then finally we discussed medullary cystic. So this is usually bilateral, but the kidneys are small and shrunken from fibrosis. There can be cysts in the collecting duct, although remember they're often not seen. Small shrunken kidneys, early onset of gout, and then renal failure. And that concludes our module on cystic kidney disease.